This is Status of States, where we explore health and healthcare across India's diverse regions with a particular focus on policy, programs, and ground realities. The Indian Constitution lists public health as the responsibility of states. Join us as we speak with health experts from different states, understanding the unique contexts, challenges, and innovations shaping public health. I'm Aditi Duneria, your host for this episode of Status of States, brought to you by the Center for Health Equity Law and Policy at the Indian Law Society in Pune. Let's dive right in. In this episode, we will journey to the state of Uttar Pradesh with Jashodhara Dasgupta. Jashodhara is an independent researcher based in India with experience on gender, public health, and rights based approaches. She led the women's health and rights organization Sahyog for 12 years and supported grassroots women's leadership for health and its social determinants in Uttar Pradesh for close to 30 years. She has been a part of setting up 4 feminist organizations in India and nurtured civil society networks on sexual and reproductive rights. She has published her research in a number of peer reviewed journals and has been a part of several academic and government committees, including the former and current Lancet University of Oslo Commission on the Political Determinants of Health. Jashodhara, we are glad to have you here. I would like to start this conversation with a broad question to you. If you were to describe the state of health and healthcare in Uttar Pradesh largely, how would you do so? And here we are talking about health in an overarching sense where we are including social determinants of health, such as gender, education, nutrition, social dynamics, etc.
Hi, Aditi. Thank you so much for inviting me to this podcast. I'm really happy to be able to share some of my thoughts based on the work that I had done in UP over several years, basically with the focus on health, but also looking specifically at the health of women and girls. Just to give you a kind of overview, my sense is that the state of health in Uttar Pradesh is impacted very heavily by a lot of social determinants. One of them, definitely the fact that UP has the largest population in India at 250 million people almost. Secondly, that UP is not a very, should we say, developed state. It is very largely agrarian and people are mostly farmers and not big farmers, but small and marginal farmers. Thirdly, we see a lot of poverty in the countryside beyond the cities. I feel that all of these impact a lot on the state of health. The fact that education is also very low in the sense that women's education is even less than 60% based on the last census of 2011. And it has a disparity of nearly 20 percentage points with men's education. So the gender differentials that we see here, the poverty and the lack of development are factors. And finally, I want to say that Uttar Pradesh is also a society that has several very marginalized groups, which are discriminated on the basis of caste, community, and religion. And I think this also impacts upon their access to healthcare and the quality of healthcare they receive.
It's very interesting the last point you made, how the social position of some individuals really affects their access to healthcare. So, if you could help us visualize what that looks like in terms of, like you said, literacy levels, a person's caste or class position, their gender, of course. So, what does this differential access to healthcare look like?
So, on the basis of the kind of research and grassroots mobilization that we had done, we have noticed that when women reach health centers, for example, the treatment that they receive depends very much on their social position. So, for example, if they go to public health facilities, normally at the secondary level is what most women are able to reach, we find that there is a lot of discriminatory behavior, which can also result in abuse or denial of care. And this impacts upon their access to quality care. Sometimes it leads to lack of life-saving care, and it could even lead to death. We also find that there is deep-seated discrimination in the minds of senior health providers, for example, doctors, also on the basis of religion. and there are very deep rooted biases. So, just to give an example, there is a bias that Muslims have too many children and their children are mostly antisocial, or Dalits are dirty and Dalits are not meant to be touched by the hand of the upper caste providers. So, we have had cases where, for example, Dalit women who have given birth in public hospitals have been compelled to clean up after themselves because no other provider will clean up for a Dalit woman or even Adivasi women. So there have been many examples that we have encountered. Unfortunately, these have impacted deeply on the quality of healthcare that people receive. And the fact that a lot of people are not so educated, the female literacy rate is quite low. It also means that there is a huge information asymmetry and therefore a power imbalance between the providers and those who come to public hospitals seeking care.
It is actually quite revealing to get this insight from your ground experiences, because of course there's a lot of invisibilization of such issues, that caste is no longer a problem and religion is no longer a problem in a lot of public narratives. But on the ground, when people are actually trying to access services, these factors play a huge role in how they are treated in such institutions. Two things I would like to touch on. You said that most people reach out for care at the secondary level, and the information asymmetry is huge, especially given the literacy gap in terms of gender. So, I'm curious to know the status of primary health care and what does the access look like at that level? And what is the status of women's reproductive or maternal health or their access to such healthcare services in UP?
I would just like to start by sharing a little bit of data, perhaps to make it clearer. So, for example, when we look at general sort of reproductive care that women mostly go for, which is for childbirth, what we find is that a lot of women are actually going into institutions for childbirth following the Janani Suraksha Yojana that was announced almost 20 years ago. And we find that there has been an increase over the last, let's say, 5 to 6 years. If we look at the data of 2020, 2021, which is in the National Family Health Survey. So, what we find is now that 83% of the women are actually going into institutions for childbirth. And the interesting figure here is that of these 83%, 58% are going to public facilities. So that means there is a very significant proportion of women who are going into private facilities. And I think that is something we will have to go a little deeper into. Secondly, we find that when women need life saving services, for example, cesarean sections, then we find that of the women who had childbirth with a cesarean section, in the public sector, only 6% of the women went, whereas in the private sector, 40% had a cesarean section. So, this to me is very telling about the state of primary health care in the state of Uttar Pradesh. And this relates to the fact that there is a very huge shortfall in terms of health budgets and in terms of skilled health workers. So, for example, we know that there has been data brought out on the number of ANMs, the auxiliary nurse midwife, who are available in rural areas. And we find that where 28,000 posts of ANMs are sanctioned, we have a huge shortfall of 7,000 posts, which means that those who are there are obviously having to work quite hard and may face burnout and overburden because the required number of staff is not there. We also know that in the primary sector, there is a huge shortfall of doctors who are not joining because they are all shifting into the private hospitals. We know that life saving care, which has to be provided by specialist doctors, has a massive shortfall in the public hospitals of Uttar Pradesh, where there are close to 3,000 posts sanctioned. We find that one third are in position and about 2,000 posts are vacant. So, this really tells us that there is an enormous lack of the skilled health workforce at the primary level. So, that brings me back to the question of why are women not going into the public sector for life saving care? So as we see, 6% women had cesareans in the public sector compared to 40% in the private sector. And this shows that in the public sector, they don't get the kind of doctors or the kind of health facilities that can actually save their lives. And so they are having to leave the public sector and take resort to the more expensive private sector. So this is something we need to look at also in the light of the kind of resources that are provided by the government for primary health care. And we know that, for example, in the health and family welfare budget, there was over the last 2 years, 3 years, a steady decline in the allocations. And what is more remarkable is that when you look at the figures from about 2 years ago, which is 2023 to 2024, you find that about 18,500 crores was allocated, but what was really spent is close to 8,000 crores. And that's a shocking figure because it means that despite the so-called high allocations to healthcare, there is massive underspending, which means that the resources are not reaching the primary health facilities. We do see in the previous year, 2024, 2025, that about 13,000 crores was allocated. The budgets have come down 5,000 crores already from the previous year. But by the middle of the year, the government realized even that much would not be spent and brought down the budget to a little over 11,000 crore. Clearly, the government is struggling to be able to spend the resources, whereas on the other side, we find that the health facilities are struggling because the staff are not in place. Doctors, young doctors in primary health centers are not attracted to join, and specialists are completely missing because they feel that they might get much better facilities in the private sector.
Thanks, Yashodhara. It's very interesting to note these stark differences in resource allocations for a state as large as UP with such a huge population. One would imagine that the government sector would be adequately resourced to at least have basic staff on the ground or some level of specialists, but the scale of vacancies that you have shared is really telling of the state of affairs. So I'm just curious about what, in your experience, could be the reason for such skewed resource allocation generally. Is it a question of how government is prioritizing the budget generally in the state? And if so, this huge allocation of the budget in the first place, but then gross underspending of the same budget, what could be the reason behind these underspends then? Even the portion that is spent, the expenditure that is made out of this budget, where is that expenditure going towards?
Let me give you the budget and resources information from a different angle. There is also a calculation called per capita expenditure by the government on health. So if you look at how much does the Indian government spend on health per capita, meaning each person of the population on average, the figure is rupees 3,169 for the country as a whole. But when you look at the state of Uttar Pradesh, the data for 2021-22, which is when we have the health accounts report, we find that Uttar Pradesh is practically at the bottom of government spending on health per capita. So, of course, at the extreme bottom is Bihar at rupees 1,300 per capita, and UP has the ignominious position of second from the bottom, which is 1497, but we can round it off to 1500. If we look at the per capita spending for what is going in the country as a whole on average, Uttar Pradesh is precisely half the spending per capita. The question arises that is it the way that the resources are distributed? Because clearly it seems that the population of Uttar Pradesh, which is 250 million people, is leading to resources being more thin on the ground. Then let's sort of juxtapose this with looking at how much people are spending on healthcare. And here, for India as a whole, the per capita spending, which is called out of pocket expenditure on health, is rupees 2,600 per head. But when you look at Uttar Pradesh, then the figure changes. And remember, this is for 250 million people. The per capita spending on health is rupees 3,014. So it's significantly higher than the Indian average. And clearly, massive amounts of money are being spent by the 250 million people of Uttar Pradesh for out of pocket expenditure. So I think that's something to really consider quite deeply. The other thing that I think we need to also examine is where is the money going? I mean, even if it is one of the lowest per capita expenses, at least there is some money because it's 250 million people. What we find is wherever the health budgets have been increased, a lot of the money is being spent on infrastructure and constructions and sometimes on purchases. But where the money is actually needed is to provide people with skilled providers, to give training to the providers, to ensure that facilities have the medicines, have the testing and laboratory facilities, have transportation for the serious patients to access healthcare. These things are missing. There seems to be a mismatch between what is needed, where it is needed, and where it is being spent. And I think there is a huge mismatch between how much people are spending from their own pockets, which leads to impoverishment, and how much is being spent by the government.
Jishudha, this point regarding out of pocket expenditure, especially, is quite disturbing to see because when you say that the government is nearly spending 1500 rupees per person, whereas an individual is nearly spending the double of that, which is around 3000 rupees, it really tells you how much an individual has to bear the burden versus the state taking care of their health, which essentially should be treated as a right. And this out of pocket expenditure, like you rightly said, is a very significant cause for a lot of people to lead them into poverty and thus the vicious cycle. So I'm curious about these recent schemes that we have been getting pan India and the state, of course, which are designed to help people with these expenditures. But it looks like despite these newer schemes, the out of pocket expenditure remains high. There are various schemes available to the people in UP, like this Mukhyamantri Jan Arogya Yojana, which is a state level version of the Pradhan Mantri Jan Arogya Yojana, the PMJY scheme, which gives people insurance cover of up to 5 lakh rupees. Then there are various specific schemes, like you said, the Janani Suraksha Yojana, for example, for women, and there are some specific schemes for children. What has been the uptake of these schemes and the larger benefit, if any? Have these schemes aided people in improving their access to health or in reducing their health expenditure on a broader scale?
I would just like to refer to, first of all, the data from 2020, 2021, which was from the fifth round of the National Family Health Survey. And in that data, when it's looking at Uttar Pradesh, it says that the proportion of women who had coverage of health insurance or health financing of some sort were 16%. And this is actually after the launch of the schemes like the RSBY, the Swasthya Bima Yojana, and it is actually 2 or 3 years after the launch of the Pradhan Mantri Ayushman Bharat Yojana. So I think the data is very telling. Why are only 16% covered? And here I'd like to just go a little bit into the way that schemes actually roll out on the ground. So the government could introduce a scheme. It could even give a budget allocation to the scheme. But I think what we first need to see is how many people get to know about the scheme. So I will just take the case of, for instance, women. Okay, so as we know, women's literacy is below 60%. If we look at women's access to mobile phones, it is less than 50%. The NFHS 5 says that women who completed high school are 40%. So this again brings out the point I made about information asymmetry. Most people do not get to even know, even if it is being publicly announced, that there is a scheme which is meant to benefit them. The second thing that happens is when there has to be enrollment of the beneficiaries, there needs to be far more grassroots push in order to make sure that those who are really the deprived and the marginalized can benefit from such schemes. Unfortunately, in Uttar Pradesh, there are huge disparities in class or income. in gender, in caste, and in religion. And because of these disparities and the information asymmetry, there is also discrimination and marginalization. So many people do not get to know. Once they even get enrolled, in today's day and age, there are huge biometric requirements. And this becomes very problematic for the poorest because A, it involves them being available for the biometric recordings. Second, where biometrics involve fingerprints, for the poor, it's very difficult because their hands get very rough owing to hard manual labor. Then, when these poor people arrive in hospitals, let's think of who is going to provide them with the care. Public health facilities at the primary and secondary level are sorely lacking in the skilled and qualified personnel who can handle serious health problems. So, what happens willy nilly is that if the poor have a complication that needs expert or specialist care, they are forced to access the private sector. Now, schemes like the Pradhan Mantri Jan Arogya Yojana, PMJAY, were meant to provide this kind of health coverage. And there was a sense that your health card, your smart card, would allow you to access up to rupees 5 lakhs in inpatient care. So, when a person reaches a hospital, if they need inpatient care and the public hospital cannot provide it because there are no skilled providers, they have to access the private sector. And there is another whole story about how the private sector capitalizes on this desperation and exploits health insurance schemes by taking money not only from the government for the health coverage, but also from the patient who is trying to access care. There have been several documented instances of double billing where the patients were meant to pay for several things and the government was also submitted bills on the same. So, this is one way in which the private sector benefits quite a lot from health insurance scheme. The private sector may also inflate costs, in which case the government would be paying some of the costs and the rest would have to be borne by the family. So, in these ways, a scheme like the Pradhan Mantri Jan Arogya Yojana, despite its good intentions, becomes very difficult to benefit from for the most marginalized and rural populations of Uttar Pradesh.
It sounds very ironic to look at it this way. The schemes that are supposed to benefit the most marginalized are by design very limited in their access or outreach, so much so that people often don't come to know of them in detail. Even when they do come to know of them, they do not have the means to actually register themselves, or even if they are registered, then the hospitals pose another barrier to how they can access those services. So, on a related note, from our conversations with experts from other states, we have seen that because of a lot of unpaid balances from the government, hospitals who were once impaneled with such schemes, where people can go and access treatment based on their insurance cards, are moving themselves out of the schemes, like they're deregistering because they are not getting paid by the government in time or their dues are not cleared. And like you said, they often coerce patients into paying as well because their balances are not cleared or the packages that they are assigned are at a very minimal cost versus what they incur. So, what is this situation looking like in Uttar Pradesh? What is the state of hospitals that are actually available under such schemes? And even if they are available on paper, the state of services once you go and try to access treatment there?
I don't have data for Uttar Pradesh specifically, but I do know that for PMJY as a whole across the country, the level of compensation given by the government to private hospitals far exceeds the amount given to public hospitals. So, while this may be correct and is probably also happening in Uttar Pradesh, that private hospitals who have been empaneled are opting out or refusing to give the services under PMJY. I think we also have to look at the bigger picture, which is that a large proportion of public resources for this health coverage are actually flowing to the private sector. We also find that the amounts that are taken as compensation are much higher in the private sector than in the public sector. So, for example, if someone came in for some serious life saving care to a public hospital, they might be spending maybe a few tens of thousands over their hospital stay. But if they went to a private hospital, it is possible that the private hospital, knowing that there is insurance coverage, would make sure that a large part of that rupees 5 lakh is already drained out by this one period of inpatient hospitalization. So we have to look at the bigger picture of how the private sector has taken a lot of the resources that were given through this scheme. The second thing is also the question of outpatient care. So, inpatient care as a medical practice is gradually reducing everywhere. So, for example, even cancer treatment now has become an outpatient activity in which you do not spend the night in the hospital. So, gradually, what is happening for people, because the PMJAY covers only hospitalization, whatever they are incurring as expenses out of pocket for OPD or outpatient care and for laboratory tests and for medicines and other investigations, it does not get covered. But it could end up being a significant part of what they are spending. And then there's also transportation, for which there are very minimal amounts that are kept within this scheme. We have to also see that the private sector can benefit enormously from the use of public resources for health coverage, even though there may be a trend of empaneled hospitals sort of withdrawing from this scheme. At this point, I'd just like to also flag another scheme that has been working in Uttar Pradesh for a very long time. This is the ICDS scheme that was meant to ensure the health of mothers and infants and small children. There is also another scheme which is for adolescent girls and youth, which is the RKSK. And these are the schemes that are supposed to ensure that youth and women and children have access to health checkups and, very importantly, to keep a track of their nutritional status. For me, it's very important to see the outcome. And if you look at the nutritional outcomes, I will just take indicator, which is anemia, and another indicator, which is the body mass index or BMI. And the National Family Health Survey, which was done in 2020, 2021, shows in Uttar Pradesh, the women whose body mass index is below normal are close to 20%. And this has only come down 5 points from the previous survey, which was done 5 years ago. We also find that anemia among women has remained practically stagnant over 5 years, which was 53, and 5 years later is 51%, which means half the women of Uttar Pradesh are actually anemic. If we talk of anemia in pregnancy, for which there are specific programs for iron supplementation, for nutrition supplements through the ICDS, the figures have remained the same over 5 years. It was 51% 5 years ago, and in 2020-21, it's 46%. Barely any change. And it's such a serious issue because anemia in pregnancy can lead to maternal death. If we look at adolescent anemia, then we find the figures are absolutely the same from 5 years. Adolescent anemia has only changed from 54% to 53%. So I think these are very, very important numbers. And it shows that the schemes for nutrition and for tracking the nutritional status of young women, girls, and pregnant women have not been able to make any impact. And the question is why? The only thing that I would say has been very, very positive is on the issue of menstrual hygiene management. I think there, either because of the schemes to distribute sanitary napkins widely to young women and girls, we find that among younger women, the use of sanitary protection in 5 years has increased very much from 47% to 73%. And this shows us that there can be a positive impact if the program is carried out in a systematic way. So I feel that these are indicators we should be looking at when we evaluate how far these other schemes have actually been reaching the population of Uttar Pradesh.
I think it is very important what you said to look at the schemes that have been making some progress and to emulate their learnings to actually reinvigorate some of the other programs or schemes which have sort of stagnated in their progress. And what you said about the out of pocket expenditures and a sort of outsourcing of responsibility towards the private sector in some ways where okay the public hospital doesn't have the infrastructure or the resources of specialized doctors to provide this treatment to you, so here is an insurance program, you may go and access it somewhere else, is also something that should be looked at closely at a systemic level to keep a check on where the government responsibilities lie. And I think this also sort of connects to the high out of pocket expenditure that people are incurring individually, which brings me to my next question of accountability and transparency. So, for instance, if I as a patient face any difficulty in accessing any health schemes or treatment at a hospital, what are the mechanisms that exist for me in that situation to get any grievance redress? On a more broader level, what is the state of transparency and accountability in the health system generally in Uttar Pradesh?
I think that once the National Rural Health Mission began in 2005, it began to institute this whole system of accountability and transparency. That was then a kind of benchmark that all other health programs and health schemes began to emulate. It has now become the norm that you must have, for instance, helpline numbers, ombudspersons, committees that are looking at grievance redress, and so forth in every place and in every program. And I think this has happened also in Uttar Pradesh. All of these have been sort of mandated, and possibly all of them are on paper. I would just like to reflect on one body which was meant to ensure quality of grassroots services, which was the Health and Sanitation Committee, and another body which was supposed to look at the quality of hospital services, which were the patient welfare committees called the Rogi Kalyan Samitis. So we have done interventions and studies through the NGO Sahyog in both of these domains to understand how far they were benefiting the people in terms of ensuring transparent and accountable high quality health services. So if we begin with, for instance, the Village Health and Sanitation Committee, we found that the public participation that is so important was entirely missing. And the Village Health and Sanitation Committee had basically shrunk into the village nurse or ANM and the village elected representative, the Gram Pradhan. And it was just the two of them who were able to access whatever resources were there or take decisions on what had to be done. But there was actually no community participation, which was supposed to be the cornerstone of the village health and sanitation committees, which in fact later became the village health, nutrition, and sanitation committees because they were also supposed to supervise the ICDS services. So the question then becomes, why didn't people participate? And that brings me back to my original points. People don't participate because A, they are not informed, B, they are too busy working, they're too poor, they're too caught up, and C, because the kind of caste and class differentials prevent their respectful involvement on these kind of platforms that are meant to ensure transparency and accountability. Having said that, I feel that some of the work that Sahyog was able to do in the districts of Uttar Pradesh in mobilizing public interest in these committees, in getting women's groups to actually work with their ASHA workers to galvanize these committees to ensure that services were provided in a timely and accountable manner. I think those experiences showed that once the community gets involved, this can actually work. I'll come to the next point, which is at the hospital level, the Rogi Kalyan Samitis. Here, the matter was slightly more problematic because the Rogi Kalyan Samitis had access to funds and were able to decide how the money would be spent for a particular hospital. Now, where money was involved, there were clearly vested interests who wanted to have control on how and where the resources would be spent. Here, too, if the committee had functioned as a public platform with the engagement of civil society, of elected representatives, and so forth, then perhaps these platforms could have taken on record the grievances. They could have ensured that the money was spent for enhancing the quality of services, for actually ensuring that patients who came to these hospitals were more comfortable. However, what happened was that the decision making got limited to just one or two people who were informed about how this was actually working. So meetings were often just held on paper. It might just be one or two functionaries within the hospital who would decide how the money was spent, and sometimes would also be doing something that involved corruption in the way the money was spent. So our study showed that we needed much more public involvement, we needed civil society engagement, and we needed elected representatives to be more aware of how these bodies were functioning and to have a greater stake in making sure that these services were of high quality and accountable to the users. It was an uphill struggle. We managed, I think, in one district to actually make a difference in the Rogi Kalyan Samitis of two hospitals. But in the other districts where we did the study and tried the intervention, it was extremely difficult. There was another research that we had conducted some years ago in which we provided people with helpline number that they could call to register complaints of corruption or demands for informal payments. So, for example, while women would go to access pregnancy care during labor, they would be asked to pay a bribe, which could range anything from 500 rupees to 1500 or 2000 rupees for the health providers to provide them with treatment and care during labor. So we wanted these to be recorded. So we had organized for an online helpline that people could call and a toll-free number to register these complaints. And we had actually got these mapped by facilities for a few districts, and we could track how many demands were made in a particular facility over how many days. And when we started this program, we had the local health officials involved and informed. When we got the data out of this digital mapping showing how many times health facilities were demanding money, were harassing patients, and so on, we invited those health officials to sit and look at the data. We showed them where the data was. The women sort of had a face-to-face interaction and pointed out that, health facility X, Y, and Z have asked for so many demands of informal payments over, let us say, the last 1 month or 2 months. And we found that even when the data was recorded digitally, even when the data was presented to the officials who were in charge of those health facilities, actually no action was taken. The demands did not stop. It was only in the case of these women who were already informed and very confident who could challenge a health provider who was asking for money or bribes. But when other patients came to those health facilities, they had the old same experience of being harassed for money and informal fees before any treatment could be provided to them. When you do have a helpline or a system of reporting, it does not mean that the data that is coming from it will actually be used for corrective measures or to redress the problem. And a very sort of positive outcome was that after our organization presented the data, the government instituted its own helpline number in which people could make toll-free calls. But unfortunately, the experience remained the same. I think that when we talk about systems working for transparency and accountability, we must be very clear about the information available in the public domain that is accessible to those who are in remote rural areas. B, we need to think about people's literacy and also their engagement in matters which are not of their day to day survival. And C, we need to think about whether there are vested interests involved in preventing people from knowing about these things. And those vested interests could use power asymmetries in order to keep people out of the loop. So, with these, I think, slightly discouraging findings, we concluded that transparency and accountability is quite an uphill struggle within the health system in Uttar Pradesh.
One very interesting thing that you said was that these are matters that people don't necessarily see as matters of their day to day survival. Because, of course, health as an issue is something that people think of momentarily. When you need treatment or when your family needs treatment, that is when you see health as an issue. Otherwise, it is not something that people think of as a personalized problem necessarily or something that affects them daily. And I think that is also a part of the reason there as to why people may or may not be very interested to necessarily participate in community decision making. And I think instituting a helpline is merely creating a channel to record complaints. But what about the next steps? What do you do once a complaint is recorded? How do you investigate and how do you ensure that there is accountability affixed and there are remedies towards that? As you mentioned, that there was no action taken towards that end. It seems like a will issue also at this point. Would it be okay to assume that the community participation is also fatigued in this way, where people are not seeing any action happening even when they are trying to complain in some ways? So the community is probably fatigued and thus not interested in participating anymore.
I think people try once or twice, but they also become cynical after a while. Because, on the one hand, they don't see a change in the behavior, there are still demands being made. On the second hand, they don't actually get any feedback. Like, the health system does not come back to them in an encouraging way and say, thank you for your feedback, and we are really trying to make these changes, etc., etc. There's no further communication. It's just like a one way thing. I pick up the phone, I make a complaint, and that's it. I mean, no one tells me whether my complaint was even heard. And I think finally, there is also a sense of priority and a fear of backlash because, as I said, there are power asymmetries. Who uses public facilities? It is the poorest who use public facilities. We know this everywhere. Anyone with economic means has already moved away to using private facilities. People don't want to face the kind of harassment that public facilities are notorious for. So when you have poor people are trying to complain about something in a public facility, the odds are that they are already afraid of backlash because of their power asymmetry, because of their marginalization. And we have had some dreadful experiences of this sort in the past. But it taught us these important lessons about being very, very conscious of caste, class, and religion asymmetries between the providers and the users of public services.
Definitely, this social dynamic of caste, class, religion, gender, it cuts through all these levels, whether it is access to treatment, whether it is the kind of treatment you receive, the treatment that you're receiving is in a dignified manner or not, if your voice is heard or not, if your participation is counted or not. It is very intersectional in that way. What you said about the public system, we definitely know that the users of the public healthcare system are at the bottom end of a very vast power asymmetry, definitely. But what about the private healthcare institutions in this case? What is the state of accountability and transparency in those places? So we know in the last couple of decades, especially, of course, all over India, but also in Uttar Pradesh, there has been huge growth of the private healthcare sector. And along with this growth, what is the situation of transparency and accountability mechanisms there? We also know that the Clinical Establishments Act that came in 2010, Uttar Pradesh passed the act and the rules were also framed in 2016. What is the status of this law itself and has it been enforced or implemented?
The minute we talk about transparency and accountability, we have to think about power. And I think it is also sometimes unfair to expect people who are already vulnerable, as those who are sick or seeking care, to enforce the accountability or to claim the accountability. that really has to come from an institution that is more in power, for instance, the government. So the government can regulate the private sector, but it's very difficult for people who are sick, who are desperate, to be able to, ensure any kind of transparency or accountability. The private sector in Uttar Pradesh has blossomed and burgeoned. There are very blurred lines between what is public and what is private. Our grassroots documentation has shown that in many district hospitals, the doctors who are supposed to be working full time are also moonlighting outside in private clinics. Sometimes they may give a sort of brief examination to a patient and then tell them, why don't you come and see me later in my clinic where I will be able to give you more time? So, this kind of blurs the experience of what is public and what is private. Secondly, the public health system today is actively encouraging people to go into the private sector when it provides resources for health coverage through a scheme like the PMJAY that has empaneled huge numbers of private clinics. This also means that because resources are being diverted away into the private sector, the public sector gets weaker and weaker. We know the fact that public sector spending is so low, the quality of services is so poor, and people's experiences are so bad that people are voting with their feet and actually moving to the private sector. My figures earlier about cesarean sections, in which I said 6% were in the public sector and 40% were in the private sector, is a clear indicator of this. So, what is happening here? What we find is that the private sector is actively benefiting from A, the government's resources through these social insurance schemes, and B, benefiting from the government's neglect of the public health system. We need to look at how health markets were created through schemes like the PMJY, earlier the Janani Suraksha Yojana, that encourage people to move into the private sector. In Uttar Pradesh, there were initially policy measures to hand over the public hospitals, for example, district hospitals, to the private sector to manage. I remember being part of efforts by networks of civil society organizations that strongly opposed this, because this was absolutely an abdication of state responsibility. Having said all this, I'd like to come back to the Clinical Establishment Act. Over many years, we had, as part of civil society campaigns, tried to make sure that the rules that were part of the Clinical Establishment Act should be notified by the government and made applicable. This would ensure some transparency, because once health facilities registered under the Clinical Establishment Act, they would have to be transparent about who were their doctors, what are the qualifications, what are the services, rates, and there would be some level of accountability, hopefully, some way to have grievance redressal of complaints. But unfortunately, there has been a very strong lobby of doctors that has been opposing the notification of the rules. And it's now been very close to 10 years. It's astonishing how the political class has not seen this as a problem. This is where I just want to flag something else. The political class has agreed with the doctors' lobby that this can be indefinitely delayed. And so the political class is perfectly happy that there should be no teeth in the law to ensure better quality, accountable services for people using the private sector. Now, this is astonishing because, for instance, during the COVID pandemic, just a few years ago, we saw how the private sector treated people who were coming there. There was extreme exploitation of patients. There was price gouging. There were all kinds of irrational costs that were added to inflated bills. The people who had the cards for their Pradhan Mantri Jan Arogya Yojana were also denied services. They also had to really run around in order to get the basic facilities. Despite that, it has not become a political priority to regulate and check private sector. And I think this brings us back to the question of political will and why this is happening. What is the complicity and what is the collusion between our elected representatives and the lobby of private doctors? I think this is a really big question.
It's a very powerful way of pointing towards this problem of why in the first place is this sort of outsourcing of responsibility or the state abdicating its responsibility happening, where they are almost pushing people into the direction of seeking private healthcare services by way of either not sourcing the public healthcare services enough or neglecting in managing any grievance redressal, neglecting in resource distribution. And this is also a very dangerous trend that we have seen across a lot of states, not just Uttar Pradesh. So, this almost encouraging people by way of discouraging them from using public healthcare services. And I believe this also sort of creates a dissonance in the public and prevents them from actually identifying health as a right. Because if you identify it as a right, then you expect the state to provide for it, which it is not doing adequately. So when you start approaching the private sector and you start paying a high price for it, you no longer see it as a right that you should be able to demand. Thus, not actively demanding it as a right could also be one of the reasons why it is not a political priority or is not coming from the point of political will, which is obviously a dangerous trend to see. So, I would like to zoom in on some positive aspects to look at this situation. Have there been any successful efforts by any civil society organizations or any community led initiatives, municipal level initiatives towards addressing any health issues? If so, what are some learnings that can be taken from them and how can they be emulated to have a bigger impact?
I have been privileged to be part of a couple of health platforms that try to work on this. And I have also noted some other efforts that have been happening in the state of Uttar Pradesh. So, for example, there was very strong opposition from civil society organizations in the past on the questions of population control. And this has managed to put a halt to a couple of things, one being the Uttar Pradesh state population policy many years ago, and more recently efforts to put in two-child norm and disqualifications for electoral candidates, for public benefits, for many kind of social schemes, etc. This two-child norm was successfully opposed because of the outcry from civil society organizations. As I mentioned earlier, the move to privatize district hospitals was also strongly opposed, and that was successful. There have been very strong use of litigation in the Supreme Court of India on the question of quality of care for reproductive health services, such as female sterilization. And I'm proud to say that I was part of a platform that brought about a change in the standards of how family planning services were to be provided and the indemnity scheme that was put in place so that anyone who faced complications after government provided a sterilization operation would be given insurance compensation. And this was due to the efforts by civil society in Uttar Pradesh. Most recently, a couple more examples come to light. One was the very, very strong voice of the media in the case of large hospitals, public hospitals, where there were suddenly a number of deaths. In one case, deaths of infants, in another case, death of patients. That happened because certain supplies were not available, electricity, oxygen, and so on. And I think the voice of the media in highlighting the problems and the issues as to why these large hospitals had not actually made sufficient arrangements for these essential life-saving supplies was very notable in Uttar Pradesh, and I'm very proud of that. And then most recently, there was a case that we were all part of, which went up to the Allahabad High Court and now is being contested in the Supreme Court. In this particular case, in the district of Muzaffarnagar in western Uttar Pradesh, a woman suffered a very serious complication of a vesicovaginal fistula during her institutional childbirth. And she had absolutely months and later years of ill health. We were part of getting her restorative surgery at a public hospital later, but the case went to court that why was a woman who went to a public hospital exposed to a situation where this condition happened to her because of the neglect by the health provider. The Allahabad High Court made a judgment which I think is absolutely path breaking and which actually would be my suggestion for Uttar Pradesh going forward. The Allahabad High Court said that the public hospitals provide care on public resources, but their care is discriminatory and also negligent and of very poor quality. The only way to improve public hospitals is to make sure that public servants, including bureaucrats, government officials, and elected representatives, only use public hospitals. If the government stops paying for their healthcare in private hospitals, they will be forced to use public hospitals and they will be forced to experience the poor quality of care. And then they will, as the policymakers, begin to make the changes that are needed to ensure that public hospitals are better resourced. This is really, really encouraging. Unfortunately, the government of Uttar Pradesh is contesting this in the Supreme Court and saying, no, we will not have our public servants use public facilities. We want public servants to be given money so that they can access healthcare in private facilities.
This example, although encouraging, it is humorous and sad at the same time how government itself is contesting to not be forced to use its own facilities, which says a lot about how their facilities actually are. Like you mentioned that this is one example that you would want UP to lead by. I would like to conclude our discussion on this forward-looking note. If you could give us 2 or 3 key solutions or measures in your view as to what is required to bring a positive change in the current state of health and healthcare in UP.
A couple of things have to be done which are pending. One, definitely the rules of the Clinical Establishment Act have to be notified and put into implementation. My second suggestion would be that we need very enhanced participation from communities, public, and from civil society organizations at every level for transparency and accountability. So we do need to have them on committees, in grievance redress platforms, systemic public hearings, and so forth, and ombudspersons who are taking the help of the community members to ensure that all the grievances, negative experiences are addressed and corrective measures put in place. My third recommendation would really be around human resources and budgets. I feel that human resource shortfalls need to be looked at very seriously. There has to be skill building, the vacant posts have to be filled. And if doctors are not willing to come into the public sector, perhaps they should be taken on as consultants, even part-time, and nurse practitioners should be upgraded to handle the more day-to-day situations. The government has made a very good start by bringing in the community health and wellness centers, and in that putting in qualified GNMs, the general nurse midwives. That's a great step, but this needs to be backed with community involvement and support, and a lot of referral linkages with the secondary and tertiary care, providing backup and transportation. In terms of budgets, I feel we do need to look very carefully at how budgets are being spent in Uttar Pradesh. I provided the shocking data from 2-3 years ago, in which 18,000 crores was actually spent at 8,000 crores. This is a very serious issue as to why there is this massive underspending. We need to look at whether all the money is just going into construction and infrastructure, or whether it is going into the improvement of the quality of health services, medicines, laboratory tests, and the training of providers. So these are my few recommendations, and I hope that these can provide pathways for us going forward to ensuring health for all in Uttar Pradesh.
Thank you, Jashodhara. I think these recommendations like notifying the rules, encouraging community participation and creating those spaces for participation, and of course, better resource allocation and management, whether it's human resource or budgetary resources, there are definitely some fundamental levers that need to move to improve the state of health system overall in the state. Thank you so much for joining us. We are grateful to get your insights and your view from the ground and above.
Thank you very much, Aditi. This was a pleasure. I look forward to our interaction. Thank you.
Thank you for joining us for this episode of Status of States. Stay tuned for more such conversations. This is your host, Aditi Doneria, signing off.